So I think moving forward, so we have Dr. Anuj, who will be talking about new age EDOF lenses and how do we titrate the requirements.
Thank you, Dr. Naren. I'm going to be talking about EDOF lenses. My talk will be divided primarily into two parts. First, I'll be talking a little bit about the EDOF lenses and then about how we end up titrating or mixing and matches based on what the patient wants. So we begin with a little bit of basics. Depth of field and depth of focus is something that we end up using interchangeably, but it's not. Depth of field is what is in the field, so in front of the lens, and depth of focus is at the retina. So when the object moves, the focus falls a little ahead of the retina or a little behind. So depth of focus is what the EDOF lenses work on. EDOF lenses have come up as a new modification in terms of the IOL power technology. We all began with monofocals and then we went on to bifocals and trifocals, and EDOF lenses over time have now filled in the gap for the period where the patients used to have a lot of dysphotoptic symptoms, and to take care of that, EDOF lenses came into the picture, and with the increased importance of intermediate vision, EDOF lenses became more significant. There are multiple types of EDOF lenses. EDOF comes basically just from extension of the depth of focus. Instead of a point focus, it extends the depth of focus of the patient. It can be done through different mechanisms. It could be through diffractive, through refractive, through hybrid diffractive plus refractive technology, through small aperture technology, and as well as through the monofocal EDOF lenses by changing the asphericity of the lens that leads to SA-induced SA-related increased depth of focus. I'll be talking a little bit about each of these technologies.
So if you look at the chart now here, can you go back, Dr. Anuj? The previous one, yeah. So like I was mentioning about diffractive and refractive, right? So if you look in this bracket of lenses, the diffractive and hybrid are actually just diffractive, finished. Okay, it's just one. It has those rings, so that means it's diffractive. And then non-diffractive, it comes into all these enhanced monofocal, small aperture, refractive. All these are non-diffractive. So this way you can make it much more simpler in terms of classification. Please go ahead.
These are the different IOLs that we have available in our entire armamentarium based on the mechanism with which they act. What happens in refractive, we always keep talking about refractive and diffractive. Refractive what happens is there are different zones. So the lens creates different focal points. So zone 1, 2, 3, 4, 5, when the rays of light pass through the different zones, they will focus at those respective focal points. And there's a smooth transition between the zones, which will lead to the smooth transition in terms of effectivity of vision across the different ranges. One issue of this is that it gets limited by pupil diameter. Compared to this, because whichever zone through which the light is passing, that is the zone from where the focus will be placed on the retina. The wavefront modifying design of the Vivity therefore falls under the non-diffractive or the refractive category, whereby the entire wavefront is modified. In diffractive, on the other hand, it works on the Huygens-Fresnel principle, and through apodization, it splits the light. In refractive, there is no splitting of light, different lights falling on different zones, leading to different focal points. In diffractive, D, there is splitting of the light. That is what gives rise to the glare and halo. As you can see in the image, the surrounding area where the light is focused, that gives rise to the glare and halo. And base apodization is where the height of the steps in terms of the steps that we can see, when the height is altered, that is apodization, because that gives rise to what the defocus curve of the respective lens will be. Then there are hybrid refractive diffractive like the synergy lens, which have a central zone, will have a 3.5 mm diameter of a diffractive element and a refractive zone as well as the aspheric element. So when you combine it, since there are diffractive zones, these patients will also experience much higher glare and halo because of the diffraction. Synergy works on the echolette design. From the edges, it does split the rays, but it has the refractive element. That is why it is a combination of it qualifies as a trifocal as well as an EDOF. In pinhole designs, just like the name suggests, all the unfocused rays are blocked and only the focused rays fall on the retina. And this happens at the expense of less light entering the eye. So only through the pinhole, light will end up reaching the eye. But since through the pinhole, all the rays are anyways focused, the patient will have an extended depth of focus in that entire zone. The SA is a higher order aberration whereby the central and the peripheral rays end up focusing at different points. So it kind of creates a Stump's conoid. So instead of creating a point focus, it creates a line focus. And through that line focus, so anywhere along the line, if the retina is placed anywhere along the line, the patient will be able to see the object that is there. And that is how it enhances the depth of focus. Important consideration ends up being patient selection. You can't use a diffractive kind of a lens in patient who already has higher order aberration because he's already prone, just like Dr. Narain said, they are already prone to glares and halos. When you put in a diffractive lens in such a patient, there will be further higher order aberrations and it will worsen the patient's vision. Since EDOFs have non-diffractive lenses are the ones that can be used in patients with post-refractive surgery if their higher order aberrations are within the normal limit. And one very important thing to take into consideration here is that if the patient has astigmatism but is not willing for a toric IOL implantation, do not implant an EDOF or a trifocal lens because that will lead to the loss of the trifocality or the loss of the depth of focus. Even when you're planning like a monovision or a micro monovision, if the patient is not willing for toric correction, then because of the poor unaided distance vision, because of the astigmatism the patient has, the beneficial effect of the micro monovision in terms of near vision will be lost. And it will come at the cost of compromised distance vision. So that is why even in micro monovision, you should go ahead with implanting a toric lens. And if the patient is not willing for a toric lens, don't implant an EDOF or a trifocal. Having said that, EDOF lenses, because of their technology, they end up, because of how the light focus on the retina, these lenses are a little better in terms of tolerating refractive surprises. Trifocal lenses lose their trifocality with residual refractive error. So when you're planning a trifocal lens or an EDOF lens, what is most important is targeting that emetropia initially. If the patient ends up having residual refractive error, your trifocal lens will mean nothing. The patient will not even be able to see near well. This extension of the depth of focus that comes in the EDOF lenses or the multiple focal points that come in the trifocal lenses, it comes at the cost of contrast. Since the amount of light going into the eye is the same, even when you consider taking in something and giving a beneficial effect of the near vision, it will come at the cost of something. So it comes at the cost of contrast, as you can see in the graphs. Titrating the EDOF depends upon two things. What is it that the patient wants, what working distance it is that the patient wants, and the defocus curves of the respective lenses. So when you're titrating for, say, a Vivity IOL, the non-dominant eye, considering that 0.2 logmar is where vision is good enough, based on the defocus curves, we can see that for a Vivity, you can, to get a vision of, say, within 0.2 logmar based on the FDA approval defocus curves, for a working distance of 40 centimeters, the target myopia should be 0.7 diopter because the Vivity provides an additional depth of focus of up to 1.5 diopters. So based on the defocus curves, you have to titrate which EDOF lens to put or which lens you can implant in the patient. Similarly, for eye hands, since the enhancement in the depth of focus of the eye hands is only up to 0.5 or 0.75, the target myopia that you will require for the other eye to give the patient good binocular near vision will be higher, say up to target myopia in the non-dominant eye of up to 1 to 1.25 diopter sphere. You can also combine technologies in terms of monofocal IOLs in one eye and a trifocal or an EDOF in the other eye, or a trifocal in one eye and an EDOF in the other eye. All of this will also depend upon the defocus curves of the respective lenses. There are multiple papers that prove that you can combine different technologies and the patient do end up becoming happy, especially this is only if the patient really requires. If the patient has come with a monofocal in one eye and has come asking for near vision in the other eye and binocular spectacle independence, you can go ahead with an EDOF lens. There are studies that also talk about using a trifocal lens, and thus you can mix and match IOLs. With toric EDOFs, when you're considering micromonovision, you should be sure that you put a toric lens if the patient has residual astigmatism, like I mentioned earlier, because if not, then the distance vision will get compromised and the benefit that you're getting with micromonovision will get compromised. So if in the first eye you've gone and gotten emetropia in right eye with a monofocal lens, the SN60 WF, and the patient wants intermediate vision, you can plan a vivity in the other eye with target of emetropia. That will, with the left eye, you can see that the patient will end up having up to 0.2 with targeting of emetropia. But if the patient wants near vision as well, then in the other eye you should plan vivity with a target of minus 0.75. So this titration will depend upon the defocus curves of the lenses that you're trying to implant. So this is a case which was normal. We planned emetropia in one eye and the patient wanted near vision as well. So we went ahead with a vivity lens and we planned micromonovision in the other eye, and the patient ended up having good vision across all range of distances. And this is another patient where we planned a toric lens in the other eye with a vivity with micromonovision, and this patient also had good binocular distance intermediate and near vision and was happy for all range of distances. Thank you.
See, one of the most important, I would say, among all these talks for a successful presbyopic lens implantation is counseling. This is the most important part. Please do not underestimate it. You really need to talk to the patient, and please do not promise you will be completely spectacle independent. That word shouldn't be there. You will never require glasses. All these words should never come. Whenever you're counseling your patients, let's say if they're going with a trifocal trifocal IOL, then what you tell the patient is, most of the time, at all distances, you won't require glasses. Okay? This is a simple term. At all distances, at least most of the time, at all distances, you won't require glasses. Please use the same words so that the acceptance is better. The other thing is, what you have to add to this point is, let's say, you have these patients, no, very small, when the lighting is not good, I can't see that well for near, right? What is your answer for this is, for these lenses to work really well, light is very, very crucial. Okay? It's a very simple play of words. For this lens to work really well, light is very important. So that is why make sure you read in good lighting. So this will solve all the issue. If you just simply say, no, use more light, use this, then they'll say, no, why I have to use, they'll start questioning. You just have to say, that's how the lens works. Light is very important for its functioning. Simple, period. And for EDOF IOLs, always say that tell the patient that the near vision is better than a monofocal, but still you'll require glasses for near. Even though you're planning a micromonovision, trying to make them independent bilaterally for distance and all distances, do not promise that in the beginning. You say that you require probably for reading purpose. Then once you finish one of the eyes and the patient's very happy for distance, when you're planning the other eye, then you just crop up the question about are you interested in this micromonovision where we target the other eye a little more near. So that time when you get that and you hit the target and you binocularly the patient's doing really well near, he felt like you're giving something that is completely extra, right? So you under-promised and you over-delivered. So the patient is extremely, extremely happy. So these small tips and how you counsel the patient is very important in these scenarios. If anyone, we thought we'll keep the questions at the very end of the session. If anyone has any questions from the audience, anything and all from all the talks what is spoken before, please, we are open for questions.